Pneumonia is so devastating, it was once described as the captain of death.
Quite a title, isn't it? Really speaks to its historical impact.
It really does. A disease that fills your lungs with fluid to create a slow, terrifying sensation of drowning from within. Can you imagine what that feels like?
It's a frightening thought. The body fighting for air against itself, essentially.
Pneumonia can trigger fevers high enough to cause delirium and a cough that produces bloody, rust-colored sputum.
Yeah, those are classic, severe signs.
In its most aggressive forms, the infection becomes necrotizing, which means it literally consumes lung tissue and leaves devastation in its wake.
That's thankfully rarer, but it shows the potential severity we're dealing with.
Now, the progression of this lung infection typically follows four distinct pathological stages, which are congestion, red hepatization, gray hepatization, and resolution.
Those are the classic stages, especially for bacterial pneumonia. They describe what's happening right down at the tissue level.
Today, we are going to discuss each one in detail, and we are going to answer the most pressing questions. What is pneumonia? Who is at risk? Is pneumonia contagious? What are the four stages of pneumonia, and how can you prevent it?
Sounds like a good plan. There's a lot to unpack there.
Absolutely. Let's take a deep dive into understanding this critical illness. So right off the bat, let's start basic. What exactly is pneumonia? When someone says pneumonia, what's actually happening inside their chest?
Okay, so think about your lungs. They're made up of these tiny little air sacs, like microscopic balloons called alveoli. Millions of them.
Right, the parts that actually grab the oxygen.
Exactly. Normally, when you breathe, air fills these sacs, oxygen passes into your blood, carbon dioxide comes out, simple exchange. But with pneumonia, these tiny air sacs, or sometimes the small airways leading to them, get infected.
Infected by what? Bacteria, viruses?
It could be bacteria, viruses, or sometimes even fungi. Whatever the cause, the body reacts with inflammation.
And inflammation means?
It means swelling, and crucially, those air sacs start to fill up. Not with air, but with fluid, like inflammatory fluid, and pus.
Pus, so dead cells and stuff.
Yeah, white blood cells rushing to fight the infection, dead tissue cells, the invading germs. All that thick fluid fills up the space where air should be.
So that's why people get short of breath. The lungs are literally like waterlogged.
That's a really good way to put it. They're congested, waterlogged, and that makes it incredibly difficult for oxygen to get across into the bloodstream. Your lungs just can't do their job properly.
And it's not just one thing, right? It can be mild or really severe.
Absolutely. It can range from something that feels like a really bad chest cold, maybe keeps you home for a week, to something incredibly serious, life-threatening, needing hospital care, even an ICU.
Okay, that gives a clear picture of the internal battle. Now, the big question a lot of people have, can you catch it? Is pneumonia contagious?
Yes. Generally speaking, the germs that cause pneumonia can spread from person to person.
How does that usually happen? Is it like catching a cold?
Pretty much the same way, yeah. It's mostly through respiratory droplets. Someone who's infected coughs or sneezes, and tiny invisible droplets containing the bacteria or virus get sprayed into the air.
And if you're nearby?
If you're nearby and you breathe those droplets in, the germs can potentially set up shop in your respiratory tract.
Does that mean anyone who breathes them in gets pneumonia?
Not necessarily, no. A lot
Hmm.
depends on, how many germs you inhale, how strong your own immune system is at that moment, and the specific type of germ. Your upper airways have defenses to trap and clear a lot of stuff.
Ah, so it's only if they get past those defenses and down into the lungs.
Right. Especially if your defenses are a bit weakened for some reason, maybe you're already run down, or you inhale a larger amount.
And if someone is sick with pneumonia, how long are they typically contagious for? When can you stop worrying about catching it from them?
It varies a bit. Generally, they're considered less contagious once their fever has gone down and they're clearly starting to feel better. If it's bacterial pneumonia and they started antibiotics, that helps a lot.
How quickly do the antibiotics reduce contagiousness?
Pretty quickly, actually. Antibiotics start killing the bacteria rapidly. So often within maybe 24 to 48 hours of starting the right antibiotic and seeing the fever resolve, the person is much, much less likely to spread it.
And for viral pneumonia, like from the flu?
For viral pneumonia, it's more tied to the course of the underlying viral illness. You're most contagious when you have active symptoms, coughing, sneezing, fever. As you start feeling better, the amount of virus you shed decreases and you become less contagious.
Okay, that's useful info. Now, you mentioned bacteria, viruses, even fungi. It sounds like there isn't just one pneumonia bug. Are there different types we should know about?
Definitely. We classify pneumonia in a few different ways. First, by the type of germ causing it, As we said, bacteria, viruses, and fungi are the main culprits.
Which one is most common?
Bacteria are the most common cause overall, especially in adults.
Is there one particular bacterium that shows up most often?
Yes, the number one bacterial cause is Streptococcus pneumonia. You might hear it called pneumococcal pneumonia. It's very common, but lots of other bacteria can do it too. Then you have viruses, things like the influenza virus, the flu respiratory syncytial virus, or RSV, which is common in kids but affects adults too. And of course, SARS-CoV-2, the virus causing COVID-19, is a major cause of viral pneumonia we've all become familiar with.
Right. Fungi seem less common.
They are, yeah. Fungal pneumonia is more likely in people with weakened immune systems, or sometimes in specific regions where certain fungal spores are common in the environment.
So classification by germ type. Any other ways?
Yeah, we also classify it based on where you likely got the infection. This is important because it can give clues about the likely germs involved and how serious it might be.
Okay, like,
The most common is community-acquired pneumonia, or a CAP. That's pneumonia you pick up out in your everyday life at home, work, school, just living normally.
makes sense. What else?
Then there's hospital-acquired pneumonia, or HAP. This is pneumonia that develops after someone's been in the hospital for at least 48 hours for some other reason.
Why is that distinction important? Are the germs different?
Sometimes, yes. Hospital environments can harbor bacteria that are more resistant to common antibiotics, so HAP can sometimes be harder to treat. Plus, people in the hospital are often already sick or vulnerable.
I see. Any other categories?
There's a specific type of HAP called ventilator-associated pneumonia, VAP. This happens in people who are critically ill in the ICU and need a mechanical ventilator to help them breathe. The breathing tube itself can unfortunately provide a pathway for germs to get into the lungs.
That sounds really challenging.
It is. And then there are a few other specific types. Aspiration pneumonia happens if you accidentally inhale food, liquids, vomit, or even saliva down into your lungs instead of your stomach.
Oh, like something goes down the wrong pipe.
Exactly, but with infectious consequences. And there's Legionnaire's disease, which is a severe bacterial pneumonia caused by Legionella bacteria. People usually get it from inhaling contaminated water mist, maybe from large air conditioning systems or whirlpool spas.
Wow, okay. So lots of different angles of germ, where you got it. It really highlights how complex it is.
Yeah.
Which leads to the next big question. Who actually gets this? How do the germs get down there, and who's most likely to develop the infection?
Well, our bodies are pretty good at protecting our lungs. We have defenses in our nose and throat hairs, mucus, coughing reflexes to trap and expel most things we breathe in.
Huh.
But sometimes germs get past those defenses.
How?
Often it's through something called microaspiration. This happens all the time, usually when we sleep. Tiny amounts of saliva or secretions from our upper airways, which might contain bacteria normally living there harmlessly, get inhaled down into the lung.
We all do that.
Pretty much everyone does it to some extent, yeah. Normally, the lower airways are sterile, and your immune system down there just clears out these tiny amounts. No problem. But if your defenses are weakened, or if the amount aspirated is larger, or if the germ is particularly nasty, that's when infection can start.
Okay, so who has weakened defenses? Who is most at risk?
Age is a really big factor. The very young kids under 5, especially infants, their immune systems aren't fully developed yet. And older adults, generally considered over 65, their immune systems tend to decline with age. The risk really climbs steeply after 65 and especially over 80.
So the bookends of life are most vulnerable.
That's a good way to put it. But there are many other significant risk factors. Having underlying health conditions is huge.
Like what kind of conditions?
Chronic lung diseases are a big one, things like COPD, chronic obstructive pulmonary disease, or asthma. Having heart failure, diabetes, chronic kidney disease, or liver disease also increases your risk. People with cancer, especially undergoing treatment, or those with a history of stroke, are more susceptible too.
Basically, any major long-term illness can make you more vulnerable.
It seems that way, yeah.
Yeah.
Anything that compromises your overall health, or specifically your lung function or immune response, being immunocompromised is a major risk factor. This could be due to HIV infection, taking immunosuppressant drugs after an organ transplant, or undergoing chemotherapy.
What about lifestyle? Does that play a role?
Oh, absolutely. Smoking is one of the most significant modifiable risk factors. Smokers are more than twice as likely to get community-acquired pneumonia compared to non-smokers.
Twice as likely, just from smoking.
Yep. It damages the lungs' natural cleaning mechanisms and defenses. Heavy alcohol use is another big one. Studies have shown a clear link. The risk increases noticeably with higher daily alcohol intake, something like an 8% jump for every extra bit of alcohol per day.
Wow. Okay, so smoking and heavy drinking are major risks. Anything else?
Being a resident in a nursing home is a known risk factor, often due to the combination of older age, more underlying health issues, and living in close proximity to others. As we mentioned, aspiration inhaling larger amounts of stomach contents or secretions, maybe due to swallowing problems or reduced consciousness, is a direct route for infection. Certain environmental exposures, like being around contaminated water sources for Legionella, or specific animals for less common types. Even the time of year matters. Streptococcus pneumonia infections are more common in the winter, often following colds or the flu.
So having a cold or flu can actually lead to pneumonia.
It definitely can. Sometimes the virus itself causes viral pneumonia. Other times, the viral infection damages your airways and weakens your defenses, making it easier for bacteria to invade afterwards and cause a secondary bacterial pneumonia. That's why a cold or flu that seems to get much worse instead of better, especially with new symptoms like high fever or shortness of breath, should raise concern for pneumonia.
That's a really important point. So if someone does get it, what does it actually feel like? What are the key signs your body is giving you that this isn't just a cold, that it's something deeper?
The symptoms can overlap a bit with other respiratory illnesses, but pneumonia usually feels more severe and has some characteristic signs. A cough is almost always present. It's often productive, meaning you cough up mucus or sputum.
What color is the sputum usually?
It can vary. It might be yellow, green, or sometimes, particularly with bacterial pneumonia, it could be rust-colored or even have streaks of blood in it.
Okay, a bad cough, possibly with colored phlegm. What else?
Fever is very common, and it can be quite high, sometimes causing sweats or intense shaking chills. Feeling short of breath or breathless is a major sign. You might notice it first when you exert yourself, but in severe cases, it can happen even at rest.
And chest pain, I hear that's common too.
Yes, chest pain is very typical. It's often described as sharp or stabbing, and it characteristically gets worse when you take a deep breath or cough. This specific type of pain is often due to inflammation of the pleura, the lining around the lungs. We call that pleurisy.
So cough, fever, chills, shortness of breath, and that sharp chest pain. Those are the big ones.
Those are definitely the classic hallmarks.
Yeah.
But people often experience other symptoms too. Intense fatigue or tiredness is very common. Headaches, muscle aches all over the body, what doctors call myalgia, loss of appetite, sometimes nausea, vomiting, or even diarrhea can occur.
It sounds like it can really knock you out systemically, not just in the lungs.
It absolutely can, and it's important to know symptoms can sometimes present differently depending on the person.
Oh, so like in older adults?
Exactly. In older adults, confusion or a sudden change in mental state, like disorientation, can be a really prominent sign, sometimes even the first or only sign before a significant cough or fever develops. This might be due to low oxygen levels affecting the brain.
That's crucial to know for caregivers. Any other major warning signs?
A really alarming sign in anyone is cyanosis. That's a bluish tint to the lips or around the mouth, or sometimes in the fingernail beds. It means oxygen levels in the blood are dangerously low, and it's a medical emergency. Call 911 immediately if you see that. Doctors might also notice other signs like a very fast breathing rate, a rapid heart rate, maybe low blood pressure. And when they listen to the lungs with a stethoscope, they might hear specific sounds like crackles or bubbling noises over the infected area.
You mentioned variations. How might symptoms look different in kids, or maybe between bacterial and viral types?
Yeah, the presentation can shift a bit. In young children, besides cough and fever, you might see them breathing very fast, or you might notice retractions where the skin sucks in between the ribs or at the base of the neck with each breath. Nasal flaring is another sign of difficulty breathing in babies. Sometimes if they just had vaccines, some minor side effects like irritability or low fever might muddy the picture a little initially.
Okay. And older adults, besides confusion?
As we said, confusion is key. They might also just have less dramatic symptoms overall, maybe a lower fever or less of a productive cough compared to a younger person. Sometimes it's just increased weakness, fatigue, or feeling generally unwell, which can make it harder to diagnose quickly if you're not thinking about pneumonia.
What about bacterial versus viral? Is there a typical difference in how they start?
Often, yes. Bacterial pneumonia frequently has a more abrupt onset. You might feel fine one day and then suddenly get hit with high fever, shaking chills, bad cough, and chest pain pretty quickly.
Like it comes on strong.
Exactly. Viral pneumonia, on the other hand, might start more gradually. It could feel like a typical cold or flu at first, maybe some muscle aches, headache, a dry cough, and then over several days it gets progressively worse. The fever might climb, the cough might become productive, and shortness of breath develops as the infection moves deeper into the lungs.
So bacterial often hits fast and hard. Viral might creep up more slowly.
That's a common pattern, though not always the case. The really important distinction, though, is less about the symptoms and more about the treatment. Bacterial needs antibiotics, viral generally doesn't, unless a secondary bacterial infection happens. And it's crucial to realize pneumonia is much more serious than just a common cold. A cold is usually upper respiratory, nose, throat. Pneumonia is down in the lungs, affecting your ability to breathe properly.
That's a vital distinction. If that cold seems to be heading south, getting worse, especially with breathing issues or chest pain, time to get it checked.
Absolutely. Don't wait on those symptoms.
All right, we've got a good handle on what it is, who gets it, what it feels like. Now, let's dig into the mechanics of how it progresses, especially bacterial pneumonia. You mentioned those 4 distinct stages. Can we walk through them one by one? What's happening inside the lungs at each phase?
Yes, this is the classic description of how lobar pneumonia, a type often caused by bacteria like strep pneumo, progresses pathologically. It's like a 4-act play inside the lung tissue.
Okay, Act 1. What's stage 1?
Stage 1 is congestion. This happens very early, usually within the first 24 hours after the bacteria have successfully invaded the alveoli. The body immediately recognizes the invaders and starts responding.
How does it respond initially?
The first thing is increased blood flow to the affected area. The tiny blood vessels, the capillaries surrounding the air sacs, they dilate and become engorged with blood. This brings immune cells to the site, but it also causes the lung tissue to become, well, congested.
Like a traffic jam of blood cells?
Sort of, yeah. And fluid starts to leak out from these engorged capillaries into the air sacs themselves. It's a thin, watery fluid at this stage, often containing bacteria and maybe the first few arriving white blood cells like neutrophils. The airways start to swell a bit too.
So the lung tissue itself starts to feel different.
Exactly. If you could touch it, the affected part of the lung would feel heavier, a bit boggy and swollen because of this increased blood and early fluid accumulation.
And symptom-wise, what's happening during congestion?
This is typically when the initial symptoms start appearing. You might notice the beginning of a cough, maybe still dry at this point. Fatigue starts setting in, fever might begin to rise. You could feel some early chest discomfort or pain, and maybe just a hint of difficulty breathing, like your breathing feels a bit heavier. It's the very start of the inflammatory process.
Okay, congestion, the initial alarm bells, and fluid buildup. What comes next? Stage 2 sounds dramatic. Red hepatization.
It is dramatic, visually and pathologically. Red hepatization typically kicks in around day 2 or 3 and might last for another couple of days. This is when the infection is really raging and the body mounts a massive inflammatory response.
What makes it red?
Huge numbers of red blood cells leak out of those capillaries and pour into the air sacs, along with tons more white blood cells, especially neutrophils, the bacterial fighters, and a protein called fibrin, which is involved in clotting and forms a mesh-like network.
So the air sacs are literally getting packed solid.
Completely packed solid. With red cells, white cells, fibrin, bacteria, cellular debris, the works. The air that should be there is pushed out. Because of the sheer volume of red blood cells flooding the area, the affected lung tissue takes on a distinct reddish appearance.
And hepatization, what does that mean?
Heper is Greek for liver. Because the lung tissue becomes so dense, firm, and completely airless due to being packed with all this inflammatory material, its texture and appearance actually start to resemble liver tissue.
Wow, the lung tissue turns solid and red, like liver. That's intense. I assume symptoms are peaking now.
Absolutely. This is often when people feel the sickest. The fever is usually high, chills can be quite severe. The cough is typically very productive, often with that characteristic rust-colored or bloody sputum because of all the red blood cells in there.
And breathing.
Breathing becomes much more difficult because a significant portion of the lung is essentially solidified and can't exchange oxygen. That pleuritic chest pain, the sharp pain with breathing or coughing, is usually very prominent too.
Is the stage particularly dangerous?
It carries significant risks. One major concern during red hepatization is bacteremia. Because the inflammation is so intense and the capillaries are leaky, the bacteria multiplying in the lungs can escape into the bloodstream.
The infection spreads beyond the lungs.
Yes, this happens in a surprisingly high number of cases of pneumococcal pneumonia. Estimates range up to 25% or even 30%. Once bacteria are circulating in the blood, they can travel anywhere in the body, potentially causing infections in other organs like the brain lining, meningitis, or heart valves, endocarditis, or leading to sepsis, which is a life-threatening whole-body inflammatory response to infection.
Okay, red hepatization sounds like the critical battleground, the peak of the illness with serious risks. What happens after this intense red phase? Does it just stay like that?
No, the lung tissue changes again. The third stage is gray hepatization. This usually begins around day 4 to 6 and can last for several days, maybe 4 to 8 days. The lung tissue is still firm, dense, and airless, still hepatized, but the color changes.
From red to gray. Why?
The intense red color starts to fade because the red blood cells that pack the air sacs in the previous stage begin to break down and disintegrate. They're allyzed, essentially. What remains dominant are the white blood cells, especially macrophages, which are now arriving in larger numbers to start cleaning up the debris, along with the fiber network and pus. This mixture gives the lung tissue a grayish or yellowish gray appearance.
So the red cells are gone, but the inflammatory gunk is still there.
Precisely. The battle is still ongoing, but the composition of the inflammatory exudate, the stuff filling the air sacs, has shifted. Macrophages are starting the cleanup, but the area is still consolidated and non-functional.
How are symptoms during gray hepatization? Still bad.
Symptoms are definitely still present. The fever might start to come down slightly in some cases, especially if treatment is working, but cough, breathlessness, and chest pain usually persist. This stage represents the transition from acute, intense inflammation towards the beginning of the cleanup process. However, it's also a period where, if the infection is very severe or wasn't treated effectively, some serious local complications within the lung can really become established or apparent.
What kind of local complications are we talking about?
Well, one possibility is the formation of a lung abscess. This is basically a walled-off pocket of pus that forms within the damaged lung tissue itself.
How would you know if an abscess formed?
It might cause symptoms like an increase in cough, often producing large amounts of sputum that might be foul-smelling. The fever might spike again or just refuse to go away. Night sweats, weight loss, sometimes coughing up blood, and persistent chest pain can also be signs of an abscess.
That sounds nasty. Any other potential complications?
Yes, another serious one is empyema. This is where the pus collects not in the lung tissue itself, but in the pleural space, that thin space between the outside of the lung and the inside of the chest wall.
So pus trapped around the lung.
Exactly. It compresses the lung and causes persistent fever and pain. Sometimes, a very severe complication called a bronchopleural fistula can develop, which is an abnormal tunnel connecting an airway inside the lung directly to that pleural space that's very difficult to manage. And in very severe necrotizing infections, significant bleeding into the lungs can occur.
Okay, so gray hepatization is still a very serious phase where the body is dealing with the aftermath of the red stage and these destructive complications can arise. What's the final act? Does it get better?
Hopefully, yes.
Mm-hmm.
The fourth and final stage is resolution. This is the recovery and repair phase. It typically starts around day 8 or 9, but it can take several weeks for the process to be complete, especially in severe cases or in older individuals.
What's happening microscopically during resolution?
This is when the cleanup crew really takes over. Those macrophages become the dominant cell type in the air sacs. They work tirelessly, engulfing and digesting the remaining neutrophils, broken down red blood cells, bacteria, fibrin, and other debris.
Like little Pac-Men cleaning everything up?
That's a great analogy. They enzymatically break down the exudate. Much of this liquefied material is then gradually reabsorbed into the bloodstream and the lymphatic system. Some of it might also be coughed up as sputum.
So the lungs are literally clearing themselves out.
Yes. As the air sacs are cleared of all that inflammatory material, the lung tissue starts to return to its normal structure and function. The inflammation subsides, the swelling goes down, and the tissue becomes soft and spongy again, able to fill with air and participate in gas exchange properly.
And symptom-wise, this is when you finally start feeling better.
Definitely. During resolution, the fever typically resolves completely. Breathlessness steadily improves as more lung tissue becomes functional again. Chest pain usually lessens significantly. Energy levels slowly start to return.
Does everything go back to normal right away?
Not always. The cough is often the very last symptom to disappear. It can linger for weeks, sometimes even a month or two after the infection itself is gone. This is because the airways are still healing and need time to fully clear out any residual mucus or debris. Some fatigue can also linger for a while.
That makes sense. The body went through a major ordeal. So, to recap the stages: congestion, Early swelling, fluid. Red hepatization, packed solid with red cells, fibrin, peak inflammation. Gray hepatization, red cells break down, gray appearance, cleanup starts, risk of complications. And resolution. Macrophages clean up, lungs clear, symptoms improve. Understanding that flow is really helpful.
It provides a framework for understanding the disease process over time.
Okay, so moving on from the stages inside the body, let's talk about what happens when someone seeks medical help. If they have these symptoms, how do doctors actually figure out, yes, this is pneumonia and not, say, just severe bronchitis or something else? And then what's the plan?
Right. Diagnosis is key. It usually starts with the basics. The doctor listens carefully to your description of your symptoms when they started, what they feel like. Have you had fever, chills, chest pain, productive cough? They'll ask about your medical history and risk factors we discussed earlier.
And the physical exam, listening to the lungs.
Absolutely. Using a stethoscope to listen for abnormal breath sounds is crucial. They might hear crackles, sometimes called rales, which sound like Velcro being pulled apart, or bubbling sounds over the infected area. They might also hear bronchial breath sounds harsher, sounds heard, where you should normally hear softer ones, or notice areas where breath sounds are diminished or absent, suggesting consolidation or fluid. Percussing or tapping on the chest might also reveal dullness over an affected lobe.
But listening isn't always enough, right?
Correct. While the history and physical exam are vital, imaging is usually needed to confirm the diagnosis and see the extent of the infection. A chest X-ray is the standard first step.
What does pneumonia look like on an X-ray?
It typically shows up as an opacity or a white area in the part of the lung that's infected. This represents the fluid and inflammatory cells filling the air sacs, blocking the X-rays from passing through as easily as they do through healthy air-filled lung.
Is the X-ray always definitive?
Not always.
Mhm.
Sometimes the X-ray might look normal early on, or the findings might be subtle or unclear. In those cases, or if the pneumonia is suspected to be severe, or if they're looking for complications like an abscess or empyema, a chest CT scan might be ordered.
CT scan gives a more detailed picture.
Much more detailed, yes. It provides cross-sectional images of the lungs and can be more sensitive than X-ray in detecting pneumonia, especially in tricky spots. It can also help differentiate pneumonia from other conditions that might look similar on an X-ray, and it's better at showing those complications we talked about.
Okay, so imaging is key. What about blood tests?
Blood tests are very common, especially if someone is sick enough to be hospitalized. A complete blood count, CBC, is standard. It often shows an elevated white blood cell count, particularly neutrophils, which points towards a bacterial infection. Other tests look for signs of inflammation, like C-reactive protein, CRP, which is usually elevated in pneumonia. Sometimes liver and kidney function tests are done to check if other organs are being affected.
I think you mentioned a specific test that helps tell bacterial from viral.
Yes, procalcitonin. This is a really useful blood marker. Levels of procalcitonin tend to rise significantly in response to bacterial infections, but stay low or rise only slightly with viral infections or other inflammatory conditions.
So it helps guide antibiotic use.
Exactly. If procalcitonin is high, it strongly supports a bacterial cause and the need for antibiotics. If it's very low, it makes a bacterial infection much less likely, suggesting a viral cause, and helps doctors feel more confident withholding antibiotics. This is a big part of antibiotic stewardship, using antibiotics only when truly needed.
Are there ways to assess how severe the pneumonia is?
Yes, doctors often use clinical prediction rules or severity scores, especially in the emergency room or hospital. The CURB-65 score is a common one it looks at. Confusion, urea level in the blood, respiratory rate, blood pressure, and age 65 or older. Another one is the Pneumonia Severity Index, PSI. These scores help predict the risk of complications or death and guide decisions about whether a patient can be treated at home, needs hospitalization on a regular ward, or requires ICU admission.
That makes sense, triage based on risk. So once the diagnosis is made and severity assessed, what's the game plan for treatment?
Treatment really hinges on two main things: what's causing the pneumonia, bacteria, virus, etc., and how sick the patient is. And a critical point is timing. Especially in severe pneumonia or sepsis, starting the right treatment quickly, often within hours of diagnosis, can make a huge difference in outcomes.
So if it's bacterial,
If it's confirmed or strongly suspected to be bacterial, then antibiotics are the main treatment. The choice of antibiotic depends on several factors: the patient's age, underlying health conditions, severity, whether it's community-acquired or hospital-acquired, since hospital germs might need different drugs, and local patterns of antibiotic resistance.
do people treated at home get different antibiotics than those in the hospital?
Often, yes. Outpatients with milder KAP might get an oral antibiotic like amoxicillin, doxycycline, or a macrolide. Hospitalized patients usually get intravenous IV antibiotics initially, which work faster. They might start with broader spectrum antibiotics that cover a wider range of likely bacteria, and then treatment might be narrowed down later if tests identify the specific bug.
And if it turns out to be viral pneumonia?
For most viral pneumonias, antibiotics won't help because they don't kill viruses. So treatment is primarily supportive care. This means focusing on helping the body fight off the virus and keeping the patient comfortable and stable.
What does supportive care involve?
Rest, plenty of fluids to prevent dehydration, managing fever and aches with over-the-counter medications like acetaminophen or ibuprofen. Careful monitoring of oxygen levels is important too.
Are there any antiviral medications?
Yes, for specific viruses. If the pneumonia is caused by the influenza virus, antiviral drugs like acaltamivir or Tamiflu can help, especially if started within the first 48 hours of symptoms. Similarly, for COVID-19 pneumonia, specific antiviral treatments or other therapies might be used depending on severity and timing. But for many other viruses that cause pneumonia, there aren't specific antiviral drugs, so it's mainly supportive care.
Do they ever give antibiotics just in case, even if it seems viral?
That's a tricky area. Sometimes, especially if someone is quite sick, it can be hard to completely rule out a secondary bacterial infection on top of the viral one. In those situations, doctors might decide to give antibiotics just to be safe. However, guidelines increasingly encourage withholding antibiotics in milder, clearly viral cases to avoid unnecessary use and resistance. The procalcitonin test can really help with this decision. Sometimes corticosteroids are considered in severe viral pneumonia, like with severe COVID-19, to dampen down excessive inflammation. But their use is complex and depends on the specific situation.
What about people who are really struggling to breathe?
If oxygen levels are low, supplemental oxygen is given, usually through nasal prawns or a face mask. If that's not enough, or if the patient is tiring out from the effort of breathing, they might need more advanced support. This could be non-invasive ventilation, using a tight-fitting mask, or, in the most critical cases, mechanical ventilation, where a breathing tube is inserted and a machine takes over the work of breathing.
And those complications like abscesses, how are they treated?
Lung abscesses often require longer courses of antibiotics, sometimes different ones that penetrate better into the abscess cavity. Occasionally, the pus needs to be drained, either with a needle inserted through the chest wall or sometimes via bronchoscopy, a scope down the airways. Empyema almost always requires drainage, usually with a chest tube, in addition to antibiotics.
So it's a very tailored approach based on the cause and severity. Now, while someone is recovering, maybe at home after being in the hospital, or if they have a milder case they're managing at home with prescribed treatment, are there things they can do to just feel a bit better? Manage those lingering symptoms? These aren't cures, obviously, but for comfort.
Absolutely. Medical treatment is essential, but supportive home measures can definitely help with symptom relief and overall comfort during recovery.
Okay, like for that annoying cough.
For the cough and maybe a sore throat that comes with it, simple things can help. A saltwater gargle. Just mix about 1/4 to 1/2 teaspoon of salt in a glass of warm water, gargle, and spit it out, can soothe irritation and help clear mucus from the back of the throat. Drinking warm liquids is generally soothing. Hot peppermint tea is a good option. Peppermint has some mild decongestant and anti-inflammatory properties, and the warmth and steam can feel good on an irritated airway. You can even just inhale the steam carefully from the cup.
What about feeling breathless? That must be really uncomfortable.
It is. There isn't a magic bullet for breathlessness besides treating the underlying pneumonia, but a couple of things might offer slight temporary relief for some people. One is using a small handheld fan and directing the cool air towards the face. Some studies, mostly in COPD patients, suggest this can sometimes lessen the sensation of breathlessness, maybe by stimulating nerves in the face.
A fan. Interesting. Anything else?
Maybe coffee. Caffeine is a mild bronchodilator, meaning it can slightly relax and open up the airways. It's not a primary treatment, of course, and takes time to work, but if someone normally drinks coffee, it might offer a tiny bit of help. Worth asking their doctor, though, especially if they have heart issues.
Okay. And the chest pain, the pleurisy.
That sharp pain with breathing can be really bothersome. Over-the-counter pain relievers like ibuprofen, Advil, Motrin, or naproxen, Aleve, are good choices because they fight both pain and inflammation. Acetaminophen, Tylenol, helps with pain and fever but doesn't have the same anti-inflammatory effect. Just remember to take ibuprofen or naproxen with food to protect your stomach. Some people also try herbal teas known for anti-inflammatory properties, like turmeric tea, curcumin is the active compound, or ginger tea. Again, these aren't replacements for medicine, but they might offer some gentle support. A caution with turmeric.
Mm.
High doses might have blood thinning effects, so check with a doctor if you're already on blood thinners.
Good point about checking with the doctor. What about managing fever and chills?
Staying well hydrated is absolutely key when you have a fever. Drink lots of water, clear broths, or electrolyte drinks. Dehydration makes everything feel worse. Cold things like popsicles or chilled drinks can feel good and help cool you down a bit from the inside. Besides the OTC pain relievers, which also reduce fever, a lukewarm compress on the forehead or taking a lukewarm bath or shower can help lower body temperature. The key word is lukewarm, though. Avoid cold water or ice baths, as that can make you shiver violently, which actually raises your core temperature and makes you feel worse.
Right, no cold shocks. And if you have the chills?
If you're shivering with chills, despite having a fever, focus on getting comfortable. Drink warm water or tea, have some nourishing soup. Use blankets to stay warm until the chills pass. Some traditional remedies mention fenugreek tea, potentially helping to induce sweating, which can cool the body, but again, that's more traditional use than strong science.
So lots of little comfort measures that can add up. Okay, finally, let's talk prevention. This sounds like something you definitely want to avoid if possible. What are the most effective ways people can reduce their risk of getting pneumonia in the first place?
Prevention is hugely important, and thankfully, there are several effective strategies. Top of the list, I'd say, is vaccination.
Which vaccines are we talking about?
Primarily the pneumococcal vaccines. These target Streptococcus pneumonia, the most common bacterial cause. There are a couple of main types: PCV, pneumococcal conjugate vaccine, and PPSV23, pneumococcal polysaccharide vaccine. Recommendations vary slightly, but generally they're advised for all infants and young children, all adults 65 and older, and for people aged 19 to 64 who have certain chronic health conditions or risk factors like smoking or asthma.
How effective are these vaccines?
They are very effective at preventing invasive pneumococcal disease. That's when the bacteria get into the bloodstream or cause meningitis. Their effectiveness at preventing pneumonia itself is maybe a bit less dramatic but still significant. One challenge is replacement disease, as the vaccine protects against common strains. Other, less common strains not covered by the vaccine might become more prevalent over time. But overall, they are a cornerstone of prevention.
What other vaccines are important?
The annual influenza flu vaccine is crucial. Getting the flu significantly increases your risk of getting secondary bacterial pneumonia, and the flu virus itself can cause viral pneumonia. So preventing the flu helps prevent pneumonia. Similarly, staying up to date with COVID-19 vaccines is important, as COVID-19 is a major cause of viral pneumonia and can also predispose you to bacterial infections. And for children, the heat vaccine, Haemophilus influenza type B, has drastically reduced a specific type of bacterial pneumonia and meningitis that used to be common in kids.
So keeping those vaccinations current is a major protective step. What else?
Healthy habits make a huge difference. If you smoke, quitting smoking is probably the single most impactful thing you can do to lower your pneumonia risk, given that it more than doubles your chances.
That's a powerful statistic.
It really is. Reducing heavy alcohol consumption is also important. Practicing good hand hygiene, washing your hands regularly with soap and water for at least 20 seconds, or using an alcohol-based hand sanitizer if soap and water aren't available helps prevent the spread of all sorts of respiratory germs. Trying to avoid close contact with people who are sick with colds or the flu, especially during peak seasons, is also a good idea. And generally maintaining good health through diet, exercise, and adequate sleep helps keep your immune system strong.
And what about seeking medical care?
That's preventative in a way, too. If you do develop respiratory symptoms, especially if they're worsening or concerning high fever, chest pain, shortness of breath, see a doctor promptly. Getting an accurate diagnosis means you get appropriate treatment. This prevents mild cases from potentially becoming severe, and importantly, it ensures antibiotics are used only when necessary, which helps combat the massive global problem of antibiotic resistance. We don't want to use these precious drugs when they won't help, like for a virus.
That's a really comprehensive overview. It feels like while pneumonia is serious, there are definite actions people can take at every step, from prevention to seeking timely care.
Exactly. Knowledge and proactive steps are key.
All right, so we've covered a lot about this serious illness, from the microscopic changes in the lungs through the 4 stages to how we diagnose, treat, and try to prevent it. Thinking about all those risk factors we discussed, smoking, chronic conditions, age, and the prevention strategies like vaccination and hand washing. Let's turn this to you, the listener. Imagine someone you care about has several of those risk factors we mentioned. Maybe they smoke and have COPD, or they're an older adult with heart failure. They hear everything we've discussed. What's the one most important piece of practical, actionable advice related to pneumonia prevention that you would immediately give them?
Ooh, that is tough, picking just one. For me, given how common pneumococcus is, especially in those risk groups, I think I'd really emphasize checking if they're up to date on their pneumococcal vaccine.
Mm.
It's a specific action they can often take relatively easily that directly targets a major cause.
Yeah, that's a good one. Very targeted. See, I think I might lean slightly differently. While vaccines are absolutely vital, if the person is a current smoker, I think my immediate gut reaction would be to gently but firmly encourage them to seek help with quitting smoking. It's such a huge, modifiable risk factor, not just for pneumonia, but for so many things. It's harder than getting a shot, for sure, but the payoff is potentially enormous.
That's fair. Addressing those underlying lifestyle factors is critical for long-term health, too. No single right answer, I suppose.
Exactly. What one piece of advice would you prioritize? Let us know in the comments below. Thank you so much for listening. Please subscribe. And as always, have a nice day or a good night and stay safe. See you on the next